Hello, everybody. This is Jay Delvecchio. I am thrilled to introduce, again, we had her once before, about a year ago, Sue DuPont, who teaches for us down in Florida Gulf Coast University. Has been doing a wonderful job for us for, I don't know what, Sue, maybe 10 years or so. So if you would all pay attention, there'll be a test at the end. No, not actually at the end. There's a quiz. It will come to you by email with the recording, and everybody who's attending here is eligible for 1 CEC. So you just have to complete the quiz, get 80 percentile better or right, and you'll be issued the CEC. But remember, you have till Monday by 5 p.m. to get it into us, so you got plenty of time to tackle this 10-question quiz for your CEC. So, Sue, I am going to cut this loose to you. Everybody, I want to let you know I am unmuting you so you can chime in as a colleague in this field and ask questions or make comments accordingly with Sue. So just unmute your phone when you want to, ask the question, and then, of course, back out of it, mute yourself again so we don't have any background noise. Okay, Sue, all you.
Thanks, Jay. Hi, everybody. Welcome. Thanks for attending today's webinar. So just get acquainted. I'm sure most of you are familiar with the tools, but there is a mute button. Please feel free to unmute if you have to ask a question. You can also type a question into the chat box, which Jay will be monitoring and letting me know. Also, if you have a question after today, you can contact me by email. My email is on the first slide, SueDuPont_PT@live.com. And you can also check out my website, Align with Sue, where I do rehab Pilates, therapy, and sports conditioning one-on-one. So after attending this webinar, hopefully you will know a little bit more about the shoulder joint. It's a little bit more than rotator cuff and deltoids. So my goal today was really just to educate you a little bit more from a physical therapist as well as an athletic trainer's point of view. Understanding the key scapular stabilizing muscles that help maintain the optimal position when you're doing exercises for the shoulder. And also understanding which muscles tend to be overactive and underactive, especially in our older clients, because they've had a lot of years to build up some muscle imbalances and some postural asymmetries and injuries, which also tend to affect that. And also hopefully get 3 effective and safe exercises for the different muscle groups that will help you be safe and effective with your older clients. Of course, the question is, what is older? And just a promo for liability insurance, definitely carry your own liability insurance. It's very, very important to protect yourself. Older is not over 60 or 70. Older is really over 40 and 50, because that's when shoulder starts to change. And it's not a matter of if you get a rotator cuff tear, according to the orthopedic surgeons, it is when. And if you are over 50, you probably already have some arthritis and some rotator cuff tearing. It's just not bad enough for you to have pain or injury and need help with that at this point. But if you don't protect your shoulders or your client's shoulder, it can turn into an injury. Shoulder pain and injury is the second most common site of pain in older adults. And you can probably guess what the first one is. Those knees, maybe? We do tend to lose range of motion 5 to 6 degrees per decade with abduction. So abduction is raising that arm out to the side, of course. And increased age is associated with also a decrease in muscle strength. So if you ask your clients what they do for exercise, which I ask my patients and my clients, they usually tell me they walk. And I say, okay, that's good cardiovascular exercise, but what do you do to strengthen your muscles? And they look at me like I have 3 heads, because their doctor told them to walk because that's the best form of exercise. And I recently posted something on my Facebook page, which got plenty of likes and views. Is walking the best form of exercise? And my answer is, it's great if it doesn't hurt, but it's also not going to help you strengthen. It's not really going to do anything for your upper body. especially with bone density issues in postmenopausal women who absolutely need shoulder strength. And over the age of 70, that loss of strength and mobility, it starts to accelerate, becomes more and more of a problem. So we definitely want to nip it in the bud before then, because it's really hard to get it back once you've already lost it. So I want you to really rethink how you strengthen your older clients, and that definition of older is over 50 for the purpose of our discussion today. However, if someone's had a rough, very active life with their shoulders, has done a lot of heavy lifting, contact sports, bodybuilding, all of these things can add to early onset issues with the shoulder. And some of the common things we see are the rotator cuff tears, of course, that everyone knows about, arthritis and bone spurs, and of course, impingement syndrome is when you get a pain in the top of the shoulder. We call it a painful arc as you raise the arm through that 80, 90 degree motion. So when someone has pain or they had a bad experience, especially with a trainer or exercising on their own, and they get injured, they're really afraid to go back to exercising. And we definitely don't want people to be afraid. We call it a fear avoidance behavior. We really want them to feel safe. And so that's where it's really important that we can seem informed and confident with how we approach these older clients, so that they know that we understand what they're dealing with and what their fears are, and we will keep them safe. So it's been said that, you know, we talk about the core a lot and do all these crazy core exercises. Well, the scapula is actually known as the core of the upper body. I like my friend Terry Trendle for cueing into that little catchphrase there. The scapula is one of the 3 major bones that make up the shoulder joint. Can you think of the other 2 off the top of your head? The humerus is pretty easy, but the clavicle also makes up part of the shoulder joint, and it's a key component of that AC joint. So if you've seen anyone with an AC separation or a fractured clavicle and it pops up, that actually affects some of the major stabilizing ligaments of the shoulder joint and will affect your ability to raise your arm. So the scapula is also the key connector of the upper body to the trunk through the thoracic spine and the rib cage. And it doesn't actually have direct attachments to the thoracic spine or the rib cage. It's really all through soft tissue connections. So it makes it a very special joint. We call it scapulothoracic joint, but it really isn't a joint at all. But it's a really important structure and area of the body to look at. When you have a client come in the room for the first time, I'm sure you notice their posture. And so part of posture is, where is that scapula? Is it elevated? Are they kyphotic? Are they hunched over? Are they hyperextended? And so these are all things that you kind of look at and you make a mental note of in your head, but you're also thinking, or should be thinking, how is that gonna change which exercises I choose for my client? Position and stability in particular of the scapula influence spinal alignment, shoulder motion, as well as our anti-gravity activity of the trunk, and that's our ability to basically not fall down and not let gravity win. And that's definitely an issue with our seniors over 65, since 1 in 3 seniors will fall. Just an interesting note, over 30 muscles attached to the scapula. I thought that was pretty interesting. So we have a lot of redundancy in the body. Their muscles do similar functions. So if one muscle doesn't work, another muscle can take over. So for example, a common issue in older shoulders is the long head of the bicep tends to tear because it attaches up underneath the shoulder joint where that arthritis starts to form. When that long head starts to fray, they don't necessarily need to fix it because you have other muscles like the short head and some other muscles in the pecs and the coracobrachialis that can assist with some of those other functions. So a lot of redundancy. But if we do have a lot of weakness and dysfunction around those scapular muscles, in particular the scapular stabilizers, which we'll talk about in a little bit, that will affect your function and start making you think, do I need surgery? And you really should try to exhaust all rehab possibilities before you undergo shoulder surgery. I should know I've had 3 of them and I chose not to have the 4th one. So please don't have shoulder surgery. For those of you who may have had shoulder surgery, you know what I'm talking about. It's not a fun experience at all. So that forward head posture, again, that head being forward from the spine, we kind of look at the ear where it lines up with the shoulder, and however much forward that ear is from that coracoid, that top of that shoulder, that is an indicator of that forward head. So for every inch that we're in front of that line, it creates 10 additional pounds of pressure on the cervical spine. So this is where patients and clients will get a lot of headaches, a lot of neck pain and stiffness, a lot of shoulder pain, scapular dyskinesia, which is that abnormal motion of the scapula. So it's not really doing its normal function when we raise our arm, and that can change how we move, the whole movement pattern of that shoulder joint, just because of posture. So I threw this in because I found this just astounding, what a simple thing that I did with this lady. So she's probably in her 70s. You can see on the normal stance, she's basically got her belly sticking out and her shoulders are back, but they're rounded forward. So she's in hyperlordosis, but she definitely has kyphosis. You can see the rounding. Her head's tilted back, so she's got some of that forward head and that hyperextension in her neck. Her pelvis is pushed forward in front, and she's standing way back on her heels. So all we do with her, and this is actually part of the mini BEST test, which is a dynamic balance test that we use with community dwelling seniors for their balance and dynamic gait testing. If we put her on this slant board, which I just had a half foam roller, I had her put her balls of her feet up there. And if you look what happened when she did that, you can see how nicely her spine aligned. She started to activate her core, amazingly enough. And now she's a little bit more neutral. If she had not adjusted, she would have fallen forward or fallen backwards. And so she adjusted nicely, which is a good indicator that those core stabilizers do fire. They just maybe don't fire when she's in her normal stance. So she definitely needs some core training. So a little bit of review of anatomy of the shoulder. There's those three major bones. So we have the glenohumeral joint, which is comprised of the humerus, in the glenoid, which is part of the scapula. That's our ball and socket joint. Then the clavicle comes over top here, and this is that acromion process. And it forms, if you look at the red arrows on the right-hand side of the right scapula, you'll see that space that those arrows are pointing to, and that's that subacromial space, which is a common area for the rotator cuff tears. That's where several of the rotator cuff muscles attach underneath that space. And if you think if someone's got those hunched shoulders and they're compressing that space all the time, then they go to lift their arms, it really crunches that up. So I want you to do a little test for me, okay? We do this in PT school, and I love to demonstrate with my patients. So I'm gonna back up here and turn sideways. So I want you to go ahead and sit in your slumpiest, slouchiest posture that you know you're not supposed to do. And I want you to try to raise your arms as high as you can. And you'll notice that you get stuck at a certain point. You can't really get any higher, but when you sit up straight, those arms suddenly magically raise up higher. And that's the influence of that compression in that AC joint and that slouch posture that can really affect how the shoulder joint functions and moves. So this is just a little x-ray fun, looking at that same subacromial space and the glenohumeral joint in a normal shoulder on the left, that healthy shoulder. Notice the nice smooth edges around, and notice on the arthritic shoulder, you've got a lot of rough edges. It's not really smooth and round. We don't have that nice white clean bone, and there's not a lot of space in between, so the cartilage has started to wear away. And there's definitely a reduction in that subacromial arch space, which then we start to think maybe there could be some bone spurs in there causing some rotator cuff shredding and tearing. So that rotator cuff muscles, in case you don't remember, they consist of 4 muscles: the supraspinatus, which is the up top, the infraspinatus, which is just below it, the teres minor, which is down in here, and the subscapularis, which is actually not shown in this picture. It's on the front side of the anterior side of the scapula, and it's primarily involved in internal rotation of the shoulder, and as well as stabilization. So bone spurs in that subacromial arch, you can see the circle in pink. Notice that that's right where the supraspinatus and the infraspinatus run under that arch and attach over on the glenoid, so on the greater tuberosity of the humerus. So that's where a lot of those rotator cuff tears happen, is in that space. Some of the other posterior muscles in the shoulder, we've got the teres major, which actually works with the latissimus dorsi. the teres minor, which is one of those rotator cuff muscles, the infraspinatus. Notice the stabilization function that they have. So the rotator cuff really doesn't rotate the shoulder. It actually stabilizes the ball in the socket and keeps it centered. So as you're raising your arm up and down, it's not sliding up and down in the socket, giving you that impingement. When those muscles don't function properly is when you get that sliding and that instability, which then causes that impingement function. The serratus anterior is a muscle that we don't hear of very much, but that is a key scapular stabilizer. It works with rotating that scapula and that upward rotation, which is necessary, as well as that keeping that scapula against the rib cage so that we don't get that abducted scapula. So when that shoulder gets rounded and kyphotic, the scapula tend to migrate more laterally. And that's where we know then we're not getting good stabilization in these scapular muscles. So this is an interesting pie chart that I thought you might enjoy. It kind of surprised me when I came across this a few years ago. These are all the muscles that contribute to shoulder abduction. So if you look, the deltoid, the middle deltoid, which we think that's the primary movement for shoulder abduction or that lateral raise, that accounts for 50% of the muscle activity. The subscapularis, remember I just told you that muscle is in the front of the scapula and actually internally rotates the shoulder, is responsible for 30% of abduction, which is a little crazy when you think about it. The supraspinatus and infraspinatus account for another 35% combined. And the anterior deltoid actually is only 2% of that shoulder abduction movement. So if you think about if you have a tear in your supraspinatus, which is pretty common, and it limits your ability to raise your arm, well, you've got other muscles that are helping you do that function. So bear with me while I find my place here. Okay, so with shoulder abduction, it's all about the angles. So if you look at the motion, the supraspinatus actually initiates that abduction 0 to 15 degrees. The middle deltoid takes over 15 to 90 degrees. And then it's the scapular motion that actually allows us to get up or overhead. So if you've ever had shoulder surgery, not sure if any of you have, then you might remember how hard you could get up to shoulder height pretty easily, but it was really hard to get that additional motion. It takes a long time to get that. And that's because we're not getting that good control of the scapula, that upward rotation and retraction to allow the glenoid to, which is the socket, to allow that humerus to ride up without impinging. So those muscles, the serratus anterior and the upper and lower trapezius, are the muscles that really help function. So if you look at those muscles, you'll notice that the lower trap isn't something that we really talk much about, nor the serratus anterior when we're exercising shoulder joints. But after today, I'm hoping that you will rethink that. So I want to go back to this slide here. So Jay, if you can put up that polling question, just want to quiz you a little bit here. How many of these muscles are involved in shoulder abduction, are part of the rotator cuff group? So of those 5 muscles listed, the mid-deltoid, subscap, supraspinatus, infraspinatus, and anterior deltoid, which ones are part of the rotator cuff group?
Okay, let's see. What question is that? Number 1?
Sorry, that was slide 13.
So, how many of you have taken? How many of you?
Sorry, I missed a few, Jay.
That's okay. That's what makes it fun. How many consider the posture? Which patient has a rotation? Which patient? How many have done one or more? What exercise is older shoulder approved? Oh wow.
Nope. It's way before that. It's actually the 1, 2, 3, 4th question.
Oh, okay.
Does that help?
I got it. Which patient has rotator cuff tear? That's not it. Sorry.
Your character is a dad. He's a play a dad.
Somebody unmuted. Do you have a question?
He's a badass leader. And
Can you make sure that your microphone is muted, please? Because you're watching somebody's television show.
Alicia, I think there you go. Thank you. I have this one. How many of you consider the posture of your patient when designing an exercise?
Let's go with that one.
I'm sorry.
That's okay. Let's go with that one.
Right.
So look at this.
I'm going to launch this, everybody, and you'll have 30 seconds to jump on there and vote. How many of you consider the posture of your patient when designing an exercise program?
I'm just curious to see.
Okay, we got about half of them voted so far. We got about 10 seconds to go. And again, this is just some reflection on what we're about to share, and of course what you already know as we all get better here. Okay, I've got 60% of them in, so I'm going to close out this one so we can get a tally on it. I appreciate that. Okay, we have 72% always, 27% sometimes, 1% never. And I appreciate that honesty on never. So.
Thank you for that. Yeah, so, hopefully, especially with just this simple posture test, you could incorporate that in with your clients and just see. And also, if for more advanced clients, I'll put them on a BOSU, or I have a little balance disc with a board on top that I use. It's a little more stable than a BOSU. And it's a great way to just see how did they correct, or can they correct, or do they need to hold on? And you'd be surprised how many people need to hold on for dear life, because we don't challenge ourselves as we get older. And we know that that posture is going to affect the shoulders. So going back to this shoulder abduction, it's all about the angle. So the scapula, we call this triplanar motion of the scapula. So the scapula has basically 3 different movements. It can elevate and depress, so up and down. And that's the upper trap, the levator, and the lower trap in the teres major that pull down. We have retraction, or pulling those shoulder blades back, which is rhomboids and teres major. And we have protraction, or rounding those shoulders, which is the serratus anterior and the pec minor. I will tell you that if you aren't careful with your clients and you tell them to pull their shoulder blades back like a row exercise, a lot of people will tend to hinge with the thoracic and lumbar spine, and they're not actually retracting their shoulders. They're actually just arching their back and lifting the rib cage. And that's something I spend a lot of time correcting when I'm doing Pilates activities and rehabilitating shoulder joints, is to really try to minimize those compensations. Scapular tilting is the third motion, and that's just that anterior and posterior tilt of the scapula where it can tilt forward or back. So you might have heard of scapular dyskinesia. There's a little debate about whether it's really a thing or not. We know that the scapular does tend to move abnormally in patients and clients with shoulder pathology and injury. So the major muscles that are involved in rotating that scapula upward are the upper trap, the lower trap, and the serratus anterior. So you can imagine, with all of our clients having these really tight, overused upper traps, what do you think is happening with their normal upward rotation? They're getting too much scapular elevation and not enough of that rotation. And so that lower trap tends to be very underutilized. So the muscle imbalances we typically see, and I really want you to start to pay attention to this in your clients to make sure they're not overusing these muscles. The upper trap, the pec minor, highly overused, the levator scapula, the teres major, and even the bicep. You'll find that when clients are using a lot of pec minor and a lot of bicep, when they're supposed to be using the muscles in the posterior shoulder and scapular region. It's a very common compensation, especially if they're a little rounded in the shoulders. And men who have really big chests tend to be very rounded because they're so tight and need a lot of stretching in order to be able to even get to these decreased activity muscles, the mid trap, the lower trap, serratus, and the rhomboids especially. So we did say that there was a loss of range of motion and strength with aging. And so if you look at this chart, I just thought this was interesting. This is from Pike et al. In November 2022, so it's pretty recent. And I would beg to differ. Notice that this is with healthy, normal shoulders, not shoulders with any kind of pathology. So most of the people I see have about 120 to 130 degrees of elevation, which is maybe just above 90 degrees. They're saying that normally someone 18 to 35 is going to be able to reach all the way up near 180 degrees, and external rotation about 80. This is 90 all the way back. They get to at least 83. As we age, we tend to lose that motion. And notice the strength differences, especially with abduction. We go from 22 pounds up to down to 14 and a half roughly with the 66 plus year olds. Same thing with external rotation, that rotator cuff pulling outward, which is a big loss of motion and strength in the elderly. And that's also a pretty big loss with nearly 5 pounds difference as we age. And that could be more if they have any type of arthritic changes or rotator cuff tears or injuries to the shoulders as they age. So just something to keep in mind with that older shoulder, especially if they do have an injury. Make sure you take that medical history, make sure you know what is comfortable for them. There's a lot of exercises that really are not possible for some of your clients. And that's what we're going to
for you, Sue. I'm sorry.
Sure.
I think it's asked by Jennifer, what's the best computer posture in terms of protecting the shoulders?
I'm sorry, computer posture?
Yeah, I guess working at a computer.
Gotcha. Okay. Yeah, so we have what's called desk neck and text neck. We actually joke about. So text neck is when you're looking down at your phone. And we see that a lot. If you go into any doctor's waiting room, even the seniors are on their phones or their tablets or their Kindles. Then we have desk neck, which I'm at my laptop right now. So I'm going to give you my desk neck. I'm going to tilt my head up and I'm sitting here in this funky position, which is my desk neck. So when we get to normal, what we call ergonomics, we really want our screen to be at eye level. We want it to be no more than arm's length away from us. The big thing is to make sure the arms are supported on armrests so they're not suspended, and strength and putting a stretch on all the nerves and the muscles around the neck and shoulder area. And you want that 90-degree bend in the elbows. You also want the hips either at 90 degrees or a little bit higher. And a lot of ladies are a little vertically challenged and they need a step or something under their feet so they're not hanging downward. A lot of times they'll adjust their chair to get in that proper computer position, but then their feet are dangling, so they'll tuck their feet under the chair, which then just arches the back. So we do recommend that just get a little box or a foot riser to put under their feet to get them in that neutral position. And if you just look up computer desk ergonomics, you'll find a nice picture of everything I just mentioned to you. Hopefully that answers your question. Good question, though.
That's great.
So I want to show you, these are actually two of my very nice patients that I've known for years. They keep coming back. So patient A on the left and patient B on the right. So they're each attempting to do a lateral raise. I'm going to show you this one. So look at patient A and look at the difference of her trying to raise her arms, okay? And then look at patient B. There's a big difference there, but neither one is really normal. So my question for you, and Jay, this is the next polling question, 1, 2, 3, 4, numbers 5 and 6. So there's 2 questions for this poll. I don't know if you can do 2 at a time or just 1. So we'll just do the first question. Which patient has a rotator cuff tear? Patient A or patient B? So I'm going to play.
Launching it now. Which patient has rotary cuff tear? Patient 1 or patient 2? Click on them, and we're going to go for 30 seconds here to get some feedback, and then Sue can give you some feedback to see if we're seeing all the right things. Okay, we're at halfway through here. Let's see if we can get a few more. Just to click on it, and we'll tally it automatically and have it for everybody. Okay, we have almost 60%. I'm going to go ahead and close this out. We basically have 70% have patient 1, 30% have patient 2 as having the issue.
So the answer is actually patient 1 or patient A. The lady on the left has a rotator cuff tear in her right shoulder. So you can see that she has limited range of motion in general and limited strength. She's actually quite strong below shoulder height because she uses her hands to push up from her chair, but she rarely lifts her arms overhead. She just can't, actually. So there is a rotator cuff tear in that right shoulder. Now, that's not to say she doesn't have some arthritis in there as well, but you can see patient B on the right, he's not really getting that shrugging and the elevation that we typically see with the rotator cuff tear. So this just helps you identify if you do have a client who's lifting their arms and that one arm is just shrugging like crazy or they can't really get very far, then you want to think that there's probably a rotator cuff issue in that shoulder, and you want to be a little more careful with that particular client. So now the next question is, which patient has osteoarthritis?
Okay. I'm launching it now, everybody. So patient 1 is also patient A, and patient 2 is patient B. I know I'm making it complicated, but I feel you're all ready.
This is a trick question too.
We love tricks. There we go. We've got 54% in so far. Keep voting, and we'll give it another 5 seconds. Okay, I'm going to close it now. We have 58% of the vote in, and we have 63% have patient 1, 44% have patient 2.
So you're actually both correct because both patients have arthritis. It's just that patient A is more limited. So she has arthritis that affects more her left shoulder, and it's very painful. The right shoulder isn't as painful, but she has that rotator cuff tear that makes it difficult for her to lift the arm. The left shoulder has a lot of arthritis in it, and she has a lot of more limited mobility. Patient B, the gentleman on the right, he has a lot of arthritis because you can see as he gets to shoulder height, he starts to shrug a little bit. He's in very good shape for his age. He's 80 years old, but he's very active because he's the caregiver of the patient on the left. So he's very strong, but he also has a lot of kyphosis, and he does have lung issues. So that also makes it difficult for him because his rib cage doesn't move around as much as it should to get that normal elevation and normal scapular motion. So you can see the scapula, particularly on the left of the patient B, stays quite elevated through the process, and you can see the upper traps start to kick in at 90 degrees. But
yeah.
So nice job, everyone. It's tricky, but I want you to start looking for these things in your client. And the best way to look at it is look at somebody where you already know the answer. So happy to share. Now, I know you're going to be mad at me about some of these exercises to avoid. 5 things with your older shoulder. And if you're older yourself, I want you to think about these exercises. The overhead presses, the behind the neck exercises, whether it's a press up or a lat pull down, full push-ups and planks, seated dips, and repetitive reaching or lifting the exercises with the arms maintained at or near that 90 degrees of elevation. Now, one more polling question here, Jay. The next question for all of you. How many of you have done one or more of these exercises in the past week on this exercises to avoid list?
I put it in as a yes or no. How many of you done one or more of the exercises in the past week? Of the 5 you just showed us.
And it's okay if you have, if you
What's that, Sue? You broke up a little bit for a second there. Huh? Did we lose you, Sue? I think we lost you a little bit. I can tell you that we have 60% in.
Here.
Oh, okay, I can hear you now. It got a little funky for a second. We have 59% of the vote in, and 90% have yes, and 10% have no. Okay. All right, Sue, just so you know, we've lost your connection. You said you had a tricky cat. Maybe they've come through and unplugged you. These things happen. But I am here. Yeah, I have closed out the poll, and all we see right now is the question for the poll. Everybody hang on, we're having technical difficulties. She texts me that her audio says it is out. Somehow we've lost the connection here.
Are you able to go back to her slide, Jay?
No, I wish I could. She controls the slides, all our presenters do.
Okay.
Because invariably what happens is they say, hey, go forward, go back, whatever, and usually as the moderator, I'll mess it up. Oh, there we go. She went back. So obviously she can hear us. Right now it's just her audio.
Okay, I think, am I back now?
You are back.
Sorry, lost my connection. I'm in a hurricane recovery zone, so things are a little crazy here.
Okay, good.
They're fixing all the optical cables, so apologize for that momentary lapse. So
well,
what
Karen has a question. Please spell out the words for COG.
COG, oh, center of gravity.
There we go. But I appreciate everybody. Again, this is how things affect it. We have 90% said they've done at least one or more of these. 10% no, which of the 10% no, my initial thought is, are you doing tests like Sue is suggesting and getting ahead of the curve? And if you are, that's excellent, excellent news. But go ahead, Sue. I just inadvertently was my observation.
No, thank you. Yeah, so just out of curiosity, I went online and there is never a shortage of YouTube videos of people showing you exercises. So I actually looked up some of these exercises on YouTube, and there was actually a PT gentleman who was very much into bodybuilding, and he said absolutely don't do, he had rated all these shoulder exercises and said absolutely no seated dips, absolutely no upright rows, no behind the neck exercises, and he gave good alternatives as well. A little bit different than mine, but so the information is getting out there, and I think people are starting to realize you don't have to do heavyweight overhead presses. As a matter of fact, that overhead press machine at the gym, I would just stay away from it completely. It's just not, it forces your shoulder into an abnormal position. So, but that's not to mean that we still don't want to strengthen the muscles that these exercises address. But there are lots of alternatives with an older shoulder. And even for ourselves, I play tennis a lot. As a PT, I lift a lot. I have repetitive reaching. That's part of my job. So when I'm exercising, I really want to protect my body. So I do try to avoid things that stress my shoulder. And with the 3 previous shoulder surgeries, which were actually not rotator cuff tear related, they were what's called multi-directional instability, where the ligament and the capsule were loosened and had to be tightened. It was from patients pulling on my arm a couple times, more than a couple times. So there's just certain things I can't do. And so I would agree with most of the exercises in this list. Yet if you look at exercises for seniors, seated dips is one of the top 5 that they give to every senior, which is probably one of the worst exercises they could do for an older shoulder. So let's go through these one by one and just kind of see what we come up with. Okay, and hopefully my slides are going to work here. There we go. So overhead presses with weight. Now this lady, she's been training a long time, but by the time, maybe 20 years from now, she's probably going to come and see me with some shoulder issues because they start now when you're stressing the shoulder and they develop over time. Notice the forward head position that she's adapted. I worked with the US Olympic weightlifting team. They actually all wanted my abs because the clean and jerks and all those overhead motions, the only way they can get those weights over their head is to arch their back. So they were all very barrel chested and they really couldn't have the body that they wanted in order to do their sport. So, but with our older shoulders clients, we have to look at, they may not have the available range of motion. We know that they lose range of motion and strength as they age. They might have some arthritis, so it's painful to reach overhead. They may have some rotator cuff tears, the RCT, or they may have some scapular dyskinesia where that scapula is really not getting that nice upward rotation that we need to elevate that humerus in the socket. It also can trigger excess compensation with the upper traps in the levator, which will cause some impingement symptoms in that subacromial arch that we pointed out earlier. And overhead press with scoliosis can be very, very ugly. So this lady has scoliosis, and a lot of people don't know they have scoliosis because when they go to their doctor, and this is adult onset degenerative scoliosis, she did not have scoliosis as a child. The doctor doesn't look at them from the back. They're sitting down, the scoliosis isn't very prominent. So then when they come to me and I look at their posture and I look at them stand and I have them raise their arms and I'm like, whoa, what happened here? What's going on with your spine? And this is just a mess. So with scoliosis, you can see when they have that curvature, that S curve in the spine, there's also a rotational component. So the scapula, the rib cage tends to rotate. For her, it's rotating back on the right side. And that causes all of this right shoulder to get jammed up. And so the weakness then on the left side. And then of course the curve reverses in the lower body, they tend to get hip issues. So if someone's got this kind of a posture, and I always recommend look at your client's posture from the back and put your hands right on their scapula and feel where they are because you can't really see it. And make sure they're okay with you touching them, of course, but just kind of check the spinal curves, check the position of the scapula, and check and make sure that their hips are level. Watch them walk back and forth, watch them raise their arms a few times, and that's going to give you a good indication of what kind of muscle imbalances and what kind of things that you really need to work on with them instead of just a general strengthening program. Be more specific because that's really what they're paying you for that skill that you're giving them. So here's some fun things that I thought you might like. Obviously, some alternatives to overhead press. We're trying to strengthen the deltoids, a little bit of the chest. Supine or incline press-ups, because now we've taken gravity out of the equation and we're not really reaching straight up overhead. So, and if they're on a bench, their back is supported, so they're getting a little bit of help. They're not having to overcome gravity. Scaption to 90 degrees, that's the gentleman on the top right. Scaption is when we're elevating the arms in what we call scapular plane. That's where we're about 30 degrees in front of the body because the scapula has that slight angled position. So we call that scapular plane. Remember that 30 degrees because it might be important later, hint, hint, in front of the body. And we just go to 90 degrees And we use light weights. We use anywhere up to 5 pounds. When you're doing rotator cuff muscles, and particularly scapulinus for the supraspinatus muscle, we really want to make sure we're not overloading it, because these muscles are not heavy duty lifters. We keep that for the pecs and the lats. These muscles are stabilizers, so they do lots of repetitions with light resistance. The UE Ranger, that's with this lady on the bottom with her arm up. So this is a closed chain exercise, and it's a little device that you can put some, I usually have them stand on a resistance tube on one foot and put the other end around their hand and have them pressing up, and they're pushing into the device. So it gives them a sense of stabilization, a little bit of what we call pressure biofeedback, and it helps them keep their scapula down. So this time, a lot of times if someone's having trouble raising their arm, using a closed chain device like this can be really helpful. Of course, not everybody has a UE Ranger at their disposal. So the lady on the left, on her hands and knees, she is scrubbing the floor basically. So she has some gliding discs under her hands, and she's kind of doing an overhead press with one arm at a time, but she's pressing against the floor. So whenever you add pressure, you're gonna kind of get that ball stabilized in that socket a little bit better. And you've got these little mechanoreceptors in your joint that are going to sense that pressure and activate all those great rotator cuff muscles and scapular stabilizers. So when you're pushing, you're getting a nice activation and you're getting more normal motion and avoiding all those compensation patterns that we talked about. And instead of doing reps, I usually do sets of 30 seconds so they can go at different speeds. So if you do it faster, it's more of a stabilization. If you do it slower, it's more of a strength exercise. So that's just some fun things to give you for new stuff. And then
I've got a question for you, Sue.
Sure.
If you got a second. Yeah. Can UE Ranger be done on Kaiser functional trainer machine?
I would have to look that up because I'm not familiar with that machine. But if you email me a picture or a link, and I will look that up for you and see what I can find out, if that's okay.
That's perfect. That's perfect. And then we have one from Karen. So the closed chair scrubbing uses body weight.
Yes, body weight and the friction on the floor.
Good, good. Okay, and then last one here for now. What is a supine press up? That's from Michael.
Supine press up would just be like a regular bench press kind of thing, but using dumbbells instead of a barbell, because barbells tend to force the shoulder into a straight plane, and that's actually not the natural plane. Remember that scapula is in a 30-degree angle forward. So when you use a barbell, it kind of forces you to stay externally rotated, but as you press up, your natural function is to pull slightly inward and adduct. So trying to avoid those straight barbell. Incline just means, supine just means lying on your back versus
Great.
In this slide where we're lying face down. So for my Spanish clients, I impress them with my Spanish boca arriba and boca abajo. So hopefully my accent is pretty good. That's what you get when you live in Florida, clinical Spanglish. Supine chest press will be boca abajo, boca arriba, sorry. And this press ups or prone Y over the foam roller is going to be face down or boca abajo. We're using those gliders again. So I'm using my full round foam roller here. The top of the foam roller is right at the top of the sternum. So now we're getting a little bit of cervical neck stabilization too. So if somebody's got a lot of neck issues and they can't hold their head up, this may not be the right exercise for them, or you may need to find some way to support their neck. Notice that the head and neck are in line with the rest of their spine though. So we're not arching, and the knees are flexed slightly. So that helps take out some of the tendency to hyperextend the low back. So it's a little bit easier to stabilize. And she's doing that, pressing out into that Y position. So she's starting, it's kind of like a reverse lat pull down. So she's starting in with her elbows down at her side, and she's pushing out into that V position or that Y position overhead, and then pulling back down. But because she's not pushing up against gravity, she's pushing out on the floor, we can control that tendency to elevate the scapula and overactivate that upper trap. And we're getting really nice lower trap activation with this exercise, as well as a little bit in the pecs. But also lots of core stabilization going on here too, which I always love to throw core stuff in with my shoulder exercises, because time is a commodity we don't always have. Now these are some of my favorite exercises. So the guy on the right, this is a cross punch. I love cross punches. The cross punch with protraction with the gentleman in the green shirt. So you notice at the end of his punch, he's protracting or pushing the shoulder blade forward. That's a great way to activate that serratus anterior. So you're really getting a nice strengthening in that scapular stabilizer. The lady on the left, we're going to use that gliding disc again. And what she's doing is that same cross punch, but that opposite leg is on a gliding disc, and it's just basically doing a side lunge out to the side while she rotates to the opposite side. So this really gets our clients out of sagittal plane. We're starting to incorporate that triplanar movement of the body, really activating the obliques here. The glutes get to fire. And we're getting all those scapular muscles. So I love this exercise for people who are very athletic, your golfers, your tennis players, especially your older players, because they really don't rotate very well, and they definitely don't know how to put their leg in one direction and their arm in the other direction. They only know how to go in a straight line. And if you've ever seen an older person play golf, you know what I'm talking about. You really got to encourage rotation whenever you can. So these are some of my go-to favorite exercises.
Yeah, I can see why. We have a question too from Amy. So overhead presses are no. How about the lat pull?
Love lat pull downs. Love, love, love lat pull downs. And the reason I love lat pull downs is because you're not pressing up. You're pulling down, so we're getting lower trap to fire. We're getting teres major to go work with the lats, and we're getting nice scapular depression. So we're getting out of all of these muscles that tend to be tight. It's also a nice way to get a stretch, but also teach your clients the difference between shrugging, and I call it shrugging and unshrugging. So before I have my clients work with shoulder exercises, I will teach them how to shrug and unshrug. And unshrug isn't dropping, it's actually pulling the shoulder blade down. So they're learning how to activate those muscles, and they're pulling down through the rib cage rather than just dropping their arm. So, and you can do that same shrug and unshrug with the arm in an elevated position or hand on the wall. And that's a great way to just kind of increase your client's awareness of, I call it, we're gonna play a game today, where's my scapula? And so I do all these crazy exercises with them to just really teach them how to control that elevation, depression, protraction, retraction, and tilting in their scapula, so that when we do go to exercise and I start to cue them, then they can actually fire the right muscle to correct to that neutral that I'm looking for. Because otherwise, they can't feel what you're trying to teach them.
Yeah, no, that's that's beautiful. Give them that awareness, and they know how to focus and isolate with you. I got one from Janice. How about band pull aparts?
So hold on one second for that, because I think I know what you're talking about. So we're going to skip the overhead presses and the behind the neck exercises. Here's our but we're going to do lat pull downs. I don't have a lat pull down machine in my house, and this is my friend that came, so we use the Pilates bar to simulate it. So pretend the lady on the left is doing a lat pull down to the chest, which is absolutely a wonderful exercise. The bent over row is nice because you can really incorporate, but really encourage that scapular depression and to pinch the elbows in so we get that nice retraction. And the TRX lat pull is great as well. I mean, as long as they can handle that. And you might want to do that with bent knees with your clients or in a staggered stance, so they're able to, so they don't have to hold their whole body weight, because it's a little scary for them if they're not used to that type of body weight exercise.
Yeah. I've got a question again from Amy. How Speaking of shrugs, how about using heavy dumbbells for shrugs?
Not a fan, because your upper traps are already overused. So unless you really want to have big upper traps, I would really focus on middle and lower trapezius instead. And there's lots of other exercises that will do that. I mean, I think the shrugging with weights, I'd rather my clients work on depression, because that's where they're weaker in the lower trap and the serratus versus the upper trap.
Good.
So in this slide, and I'm watching our time here, so we're going to blow through some of the don'ts and focus on the do's. Very bad plank and push-up positions. I see this all the time. And my question to you is, how long do you really need to be in a plank position, and how functional is that position? Full weight bearing is very stressful on older shoulders, and they probably don't have the trunk control or the neck control to hold that position, let alone wrist mobility, which is also big issues. So knee push-ups, tabletop push-ups, wall push-ups, and you'll see the lady on the right here, she's actually on her fists because she hurt her wrist, and she's doing push-ups over the ball. So the ball is taking a lot of her body weight, so she's not all on her hands and her shoulders. So she's still getting good strengthening without actually having to overload the shoulder joint. TRX presses are good, and BOSU push-ups on the knee holding the side handles, you can add a little more scapular stabilization. Those are all fun things to add. To dip or not to dip? So this is a definite no-no, because if you just look at the position of her shoulders right now, at the stretch on the front of her shoulder, think about an older client that doesn't have that kind of mobility. I just see rotator cuff tears and arthritis and bone spurs ripping through the tissues and shredding it, let alone if they even have the mobility to do that with their kyphosis and their forward heads. So definitely an avoid thing. And instead, plenty of, the dips is a nice exercise for triceps and shoulders. There's plenty of other exercises. I like tricep push downs, reverse curls. This is doorway TheraBand for the TB, scapular depression. So we're pulling downward and encouraging. So just so shoulder extension to neutral, and encouraging the scapula to pull down at the same time. So I'm cueing her from the back there to make sure that she's activating that middle and lower trapezius. And really any safe exercise for the chest that extends the elbows without stressing the shoulder joint. So all those presses exercises that we mentioned before would be great for tricep strength without having to stress the shoulder joint. This is last polling question for the day, Jay, is which?
I'm ready.
You ready?
I am ready.
Which exercise is older shoulder approved, A or B?
Here we go. It's been launched. Everybody can dazzle us with their knowledge. Let's go. Okay, we got 42% in already. That's it. Keep it coming. There we go. There we go. We still got 10 seconds left. All right. We got a little bit of maybe almost above half. Let's go ahead, and because I know everybody's got a tight schedule, I want to make sure you guys are good. We have 56% A, 44% B.
The answer is B. So A is a common exercise that you'll see them doing in all the nursing homes with the occupational therapists. But what did we say about repetitive reaching exercises with the arm at 90 degrees? And that's where she's hanging out. Whereas the lady on the right on that bike with that basically like a Schwinn Airdyne, those arms are kept below shoulder height. She's getting a nice push-pull without being up at that 90-degree angle. So the answer is B, avoiding that 90-degree position and reaching. And same thing with your battle ropes here. This is an absolute no-no for your older shoulders. Just thought I'd show you this. There's a lot of no's in that one. Show you more of that one, but yeah, it's a definite no. But you can use devices like this, and this is the shoulder sphere. And this is a device that I actually use myself and I use with my clients. As I said, I've had 3 shoulder surgeries, so I use this little device. It's basically like a cat toy. It's a little ball in this clear plastic cylinder here. Let me stop her at a position where you can see it. And basically you're spinning that ball around continuously, which activates that rotator cuff, that stabilization function. And it's tremendous activity in the rotator cuff with the EMG studies that have been done. And you might have seen some of the professional athletes using it, football players, tennis players. I use it to train my toss for my tennis serve. So I would encourage you to look that out. It was developed by Dr. Win Chang, an orthopedic surgeon out of New York, and he's actually a friend of mine, and because he likes my talks on shoulders. So you can go to shouldersphere.com or email me if you want some more info on that. It's a really fun device to use and a lot of fun for your clients. Pilates reformer. This is a device I have in my house. I can do a whole upper body workout on this device. And it has a bungee cord resistance. If you haven't seen it yet, you can do your high rows, your low rows, triceps, biceps, basically anything. If you turn and face the other way, then you can do all your chest work. But you can also add rotation and a lot of core work, which I really like with the reformer. I use this with my clients all the time, and they really struggle because they don't know how to use their core. Everything's muscled through with their shoulders and their arms. So if you've never taken a Pilates reformer class and you're a little bit curious, I would encourage you to check it out because it's a lot of fun. There's your triceps, but you have to stabilize a lot. There's no machine and to hold you in place.
Yeah, I can see that. Quick question though we have for you. What is a seated dip with yoga block? That was from Nancy.
Yoga block. Good question, Nancy. So a seated dip with yoga block is if you have the, the old push-up handles that we used to use. If you don't have those, you can put 2 yoga blocks, one on either side. And instead of dropping off the end of the chair to do that dip, you can just encourage them to push up on the yoga blocks, because look at a lot of your seniors. If you've ever gone on an airplane, which I used to travel a lot, and someone pulls on the back of your seat, they can't get up any other way, and you feel like the chair's going to break off any minute. That's because they don't have the strength in their legs to stand up. They rely solely on their arms, or their knees are just too bad and they can't get up. So that's just a great way to put that yoga block on either side of the body and have them push up through the yoga blocks. And that way the shoulder's staying in a more neutral position rather than putting in that hyperextended position off the chair.
Nice.
Hope that makes sense.
Yeah, we have another quick one here. What manufacturer is your reformer? From Nancy.
This is a home version for Aero Pilates. I actually really like it. I've had this particular machine for about 20 years, and I just bought a new one for my clinic. The regular studio reformers cost $4,000 and up, and that particular model you can get for $500 to $700. You can even get a used one for $300 or $400, and they hold up really well. I have the box to put on it. I've got all the tools. And it's so nice to work with clients and not have to break your budget, because I just don't have the money to spend $4,000 on a reformer, and they take up a lot more room. So this is a nice one if you're training clients in your home or in your studio. It doesn't take up a lot of space and it won't break the bank.
Does the Pilates reformer work for strength as well? That's what Karen's asking.
Yes, absolutely. They have they have machines that have the more expensive machines have different springs on them that are weighted differently. The Aero Pilates uses bungee cords, and there's 4-cord machines and 5-cord machines. And by putting more cords means more strength, but less cords means more stabilization. So sometimes it's good to challenge yourself with less resistance to really make your core work a little bit more And you can even put your hands on the foot bar to do planks without being all the way down. And you can also pull on the risers or the frame to do a prone lat pull down over the box. So in part 2, I'll go a little bit more into the Pilates reformer and some of the more advanced exercises. And certainly if you have questions about it, you can contact me and I can tune you into some resources that you can check out.
Yeah, I think that's one thing we should make clear to everybody who's on here is that we are going to have, because there's so much here and the knowledge of Sue to share, we're going to have a part 2 for next month. So newsletter, we'll have it on the 1st and the 15th with the link. So if you're having problems getting your newsletter, please let us know. But there you go, Sue. I'm sorry, but we do have part 2 coming. Oh, you skipped to it right away. That's beautiful.
Yeah, I put it up there. I'm right with you.
Thank you. Thank you. Okay.
Great. So just made you a little summary chart here. Do's and don'ts. Don't do these 5 exercises. Instead, think of some other ways that you can avoid that impingement position. And just to review, that is internal rotation, elevation, and hanging out at that 90-degree position with the scapular elevated. Try to think of exercises that get away from that and work those underused muscles that we talked about earlier. The mid trap, the lower trap, the serratus, the rhomboids, right? So I hope that you enjoyed today's webinar. Again, if you have any questions or comments or want to share, please email me. I love to hear from you. And you can email me at SueDupont_PT@live.com.
Beautiful. Thanks, Sue. I look forward to part 2 myself because there's a lot of great tips in there that are something you can execute with all types of clients. And that's the game, right? To have a lot of tools to be able to have different types of clients. So
share with each other, creative.
Yeah, no, thank you, Sue, and thanks everybody. We don't want to hold everybody up. We know this is prime time to get back into working with clients in different areas. So beautiful job, Sue, and I look forward to February's.
Great, thank you everyone. Have a great evening.
Bye everybody. Thanks.